So thank you for this introduction. I want to present you our study on which person-specific factors affect the vertebral fragility in compression and flexion-compression trauma of the lower thoracic spine. This study was founded by the University of Ulm. Traumatic spinal injuries predominantly result from severe traffic or sport accidents, and they occur throughout the whole spine. The major challenge is the treatment of these injuries, since it is still not known which fracture type causes which spinal instability and which fixation technique is best to restore it again. This might be one reason why there's a complication rate reported of about 15% after surgical fixation of thoracolumbar injuries. To study biomechanical spinal instability, in vitro investigations are necessary. Our group performed a review to summarize all in vitro studies on biomechanical spinal instability. They found that specific instability properties of specific injury types are still under-investigated. Moreover, injury mechanisms behind different fracture types are not fully understood yet. However, they are crucial to generate clinically relevant injury models for in vitro testing, and thoracic injuries are under-investigated. Therefore, the goal of our study was to generate clinically relevant compression and flexion-compression injuries in the lower thoracic spine by a mechanical injury simulation, and to investigate the influence of person-specific factors on the fracture development. Therefore, we used 12 human thoracic spinal specimens, including the costovertebral joints, from level T9 to T11, with a donor age ranging from 40 to 60 years, and 4 donors were female. We divided the specimens into 2 groups based on their bone mineral density, so that each group consisted of healthy, osteopenic, and osteoporotic specimen. We then performed a mechanical trauma simulation where we first applied a preload of 400 Newton and then subjected the specimens to a displacement-controlled impact with a target compression of 20% of the T10 vertebral body height and an impact velocity of 300 millimeters per second. In the first group, a pure axial compression trauma was simulated, while in the second group, the specimens were additionally pre-flexed with a flexion moment of 10 Newton meters, resulting in a flexion-compression trauma. Coming to the results, all our tested specimens resulted sustained traumatic injuries, while 9 specimens involved the end plate. Axial compression trauma mainly led to isolated medial end plate fractures, while flexion compression trauma mainly led to medial end plate fractures in combination with ventral compression injuries. During the trauma simulation, we then evaluated fracture loads, which are defined as the maximum load before the first load drop of 10% during the load application. Here you can see the load curves respectively for all specimens. We found that in both trauma types, the median fracture load was 5 kilonewton. We were then interested in the correlation between these fracture loads and person-specific factors such as the bone mineral density. For the axial compression trauma group, we did not find any correlation between the trabecular or cortical bone mineral densities of T10 and the resulting fracture loads. However, looking at the flexion compression trauma group, there was a significant strong linear correlation between the trabecular and cortical bone mineral densities and the resulting fracture loads. We additionally looked at the correlation between the fracture loads and the donor sex, the donor age, the vertebral body height, and the degree of disc degeneration. However, we did not find any further correlations between the fracture loads and those person-specific parameters. However, there was a tendency that female vertebrae fractured under lower loads. However, due to the small sample size, statistical verification was not feasible. So to conclude, bone mineral density significantly affects the fracture loads in flexion compression trauma, but not in pure compression trauma. This might be due to the differing load distribution and higher stresses in the ventral region of the vertebral body due to the flexion component. We found no effect of disc degeneration on the fracture loads. However, previous studies showed that severe disc degeneration reduces the likelihood of generating burst fractures with end plate involvement. However, this could not be proven in our study, since the limitation is that we only investigated specimens with mild to moderate disc degeneration, and we did not include healthy or severely degenerated specimens. Moreover, we only had a small sample size, and we need to increase the samples to also address other correlation, like the influence of the donor sex. Yeah, as a take-home message, we can conclude that the risk factors for vertebral fractures vary with specific trauma mechanisms. Thank you.